Christina.
Hi, how are you?
Good. Nice to see you, and thanks for joining us today.
Yeah, my pleasure.
I think we have.
All right, James, we'll let you kick it off now.
Perfect.
All right. Hi, I'm James. I, along with Casey, will be leading the question and answer portion today, but I would like to introduce and give a little background on today's guest, Dr. Christina Fournier. Dr. Christina Fournier is an Associate Professor of Neurology at Emory University. She is the Director of the Atlanta VA ALS Clinic, Co-Director of the Emory ALS Center, and the Emory Neuromuscular Division Director. Her clinical work is focused on the care of patients with ALS and neuromuscular disorders, and her research interests include improving outcome measures and research methods for ALS clinical studies. She serves as site investigator for numerous multicenter ALS clinical trials and non-interventional ALS research studies. Without further ado, I would like to welcome Dr. Christina Fournier.
Thanks so much. I appreciate the invitation. Let me go ahead and share my screen. One second. Okay, can everyone see the slides?
Yes.
Very good. And I'm happy to field questions during this at any time. So if there's anything in the chat or anyone wants to chime in, feel free at any point.
Yeah.
So I thought today we could talk a little bit about how do we track ALS progression and why does it matter? This is a particular interest of mine. And to me, this is really kind of low-hanging fruit for ways that we can improve the way we do ALS research. And so I think it's important. They said to give a little bit about me, but James did such a wonderful introduction. I think I can glaze right over this and go right into the topic for today. So I thought what we would talk about today is I wanted to give a little bit of background on some prior ALS clinical trials and kind of the typical outcome measures that have been used in our trials to date. And then introduce some newer outcome measures that I've been working on to hopefully do more efficient trials in the future. And then kind of ends with how patients with ALS can help with us developing better outcome measures, which we hope will lead to more efficient trials and more efficient therapeutic development in the future. So how do we measure response to treatment and disease progression in ALS trials, and why does this matter? So to give a little background, many of you probably know, so riluzole was the first drug approved for ALS. It was approved in 1995. And these studies were big studies. So the phase 2 studies, the phase 2 studies are ones that look at safety and start to look at efficacy. So that enrolled 155 patients with ALS over 12 months. And then the confirmatory study, the phase 3 studies, this is the study that kind of proves the effectiveness of a drug. So 959 people with ALS enrolled for 18 months, which is a really long and really big study. And really for the amount of drugs we're trying to test now would be very inefficient. And what you could see in the graph is kind of the data that showed that riluzole works a little bit. So the top line here is the survival of the patients that were taking riluzole, and then the bottom line are the patients on placebo. And what this number means is like 100% of people in the trial are surviving here. Here it's 90%, here it's 80%. And these are months in the trial. So at 18 months, and you can really start to see it, 12 months, you could see that the patients on riluzole lived longer than the patients on placebo. So it's a modest effect, but there's been a lot of studies that have confirmed that it is a real effect with riluzole. It's just modest. But we don't want to do trials that require 1,000 patients anymore when we're testing so many drugs, and we want to move things along quicker. So to kind of summarize, when you're looking at survival as an outcome measure, there's some pros and cons to it, right? So it's objective, it's important. We know, we care about it. We know it's relevant. It's not prone to like bias or measurement error. It's survival, right? It is what it is. But The big disadvantages are that it requires these longer trials. You have to follow patients for quite a while, and it doesn't take advantage of all of the data. So you're not looking at patients who, you can't really analyze patients that survive the entire duration of the trial. So you have to follow people for a long time. And a measure of progression can kind of look at all of the patients and how they track during the trial. And surprisingly, it actually can be defined in more than one way. So some trials say define survival as like time to a ventilator or time to, not using assisted ventilation. So it actually, although it sounds like it should be simple, it's not universally accepted kind of how you define survival at trials. So then in the 1990s, this ALS functional rating scale came along, and then it got revised, and this is the version we use now. And probably all of the patients on the call who've been to ALS clinics have done this thing a million times. So it's a 12-question scale that it has 3 items that relate to kind of speech and swallowing, 3 items that focus on hand function, 3 items that focus more on leg function, and then 3 items that relate to breathing. And each item is scored 0 through 4. And then this is added up to get a sum score. So 48 would be no functional impairment at all, and 0 would be kind of the most impaired. On average, patients with ALS lose about a point per month, but it's very variable. And typically for clinical trials, this is administered by like a nurse or a research coordinator who's been trained on how to score these things. But in more recent years, it's also been kind of adapted for self-administration where patients can just complete it themselves. But there's kind of different ways to, different training protocols for how to score this and how to administer it. Like I said, in a clinical trial, it's typically administered by a rater who then scores based on the patient's responses. So this is a graph from just our clinic population. So kind of all comers into the Emory ALS Clinic, and kind of what happens with their ALS functional rating scale. So again, 48 is the highest score, 0 is the lowest. And yes, the average progression is 1 point per month. But what you can see is that it's really, really variable from patient to patient. And we know that, the actual disease course in ALS is very heterogeneous. So you see patients that progress very quickly, like each colored line is an individual patient and what their scores do over time. You also see that there's these scores that kind of bounce up and down. And so if you're thinking about, we're trying to test drugs that, might slow progression by 20%. And you're trying to measure that kind of in the sea of all this variability. And it actually can be pretty tricky to see a treatment effect through kind of the noise and through the variability. And so that's one of the challenges. And if you have a scale that isn't optimized for certain characteristics, then it can be harder to actually see a treatment effect if it's there, and can also introduce some uncertainties. So, some things to consider when we're using the ALS-FRS. And then, so this idea of responsiveness. So if you're talking about a scale and how responsive it is, so this is if a scale can detect change, if clinical change is actually happening. So if a patient is changing clinically, you want to be able to detect it. And what we see when we look at, this data was from a clinical trial database of placebo patients. They took a bunch of patients who weren't treated and looked at kind of how they changed on the ALS-FRS. And a quarter of patients that were in this clinical trial database had no decline in their ALS-FRS over 6 months. And a lot of our current trials are 6 months long. So if you think about this, this is a pretty big deal when you're doing a trial. You have an agent that you think can slow disease, but if someone's not progressing on the measure that you're using in that 6 months, and that 25% of patients, like you're gonna have no ability to detect if that drug is working or not. So it really dilutes your ability to detect a treatment effect. So the fact that this ALS-FRS is not picking up change in a quarter of our patients that are going into our trials is a really big deal in terms of seeing if a drug works or not. And I will say there's kind of this trend more recently to include faster progressing patients into trials to kind of get around this. But there's disadvantages to that too, because then less patients are able to participate, and it kind of decreases the generalizability of a study. So what you really want is some sort of outcome that can actually just better detect change in a shorter period of time. And then this is just one example, but there's things that can make the ALS-FRS kind of improve, but a patient's not actually getting cured of their ALS. So it can be things like you get a medication to reduce your saliva and that helps your symptoms, or it could just be with variability in the scoring. So I gave an example here. So this is a patient, this is a clinic patient, was not given any kind of experimental drug, who over a 6-month period had this improvement in their ALS-FRS score. And this is not an atypical thing. We see this a fair amount. And so if this patient had been in a trial, you might think that they're a responder to the drug. But then showing you kind of their overall big picture. So remember, this is the FRS improving over 6 months. These were their breathing numbers over that same 6 months. So had a clear decline in their the strength of their breathing muscles. And then this is kind of a measure of motor strength, so strength in the arms and legs, and that clearly declined over that same 6-month period. And if you kind of look at the overall trajectory, this wasn't kind of a patient that got fixed of their ALS and magically got better, but it really was just this kind of error in FRS measurement that occurred in the 6-month period. And we see this a fair amount, and it can really kind of mess up your interpretation of what's happening in a clinical trial. And then, so there's mathematical ways to measure, like, if everything in your scale is actually measuring what you want it to. So if you think about it and you say, okay, your ALS-FRS is a 36, it's implying that you're adding up like all these things that measure functional status and getting this 36 score. You shouldn't be adding in other things, right? So if I said you're like have 7 depression and 4 weakness and 5 breathing and gave you a total number, like that doesn't really make sense, right? So you have to be adding up things that are all capturing the same thing. So this is one of the questions in the FRS. So it relates to if you're using a breathing machine, so like a Trilogy or a BiPAP or a CPAP. And so if you think about 2 patients who have the same breathing strength, let's say they both have breathing numbers that are 45%. So their actual breathing function is the same, but maybe one patient uses their Trilogy or their BiPAP very frequently, and the other one chooses not to use it. Well, the one who's not using the breathing machine is actually going to score better, even though we know that the patient who is using the breathing machine is probably going to do better. So this is just one example, but there's things in the FRS that are actually not capturing functional status. And so that's a problem too, when you're using this to kind of quantify how a patient is doing and you're capturing other things. Another issue with the FRS is some categories, some scores are capturing like a really big amount of change, and then other times that same point value is capturing a tiny amount of change. And so 1 point on the FRS doesn't really equal like a specific unit of function, which ends up being a problem when you're using the sum scores. This is an example. So in the instructions that the coordinators get when they're doing this for a trial, it says that if you go from climbing stairs normally to holding a handrail, that's supposed to be a jump from a 4 to a 1. So that's not a really big functional change to go from climbing stairs normally to climbing stairs with holding the rail, but that would be a 3-point change in that case. But on question 8, the walking question, if you go from walking normally to not being able to walk at all, even with equipment, that would be a 3-point change. And that's like a really big functional change. So it means that 1 point or 2 points or 3 points on the FRS doesn't necessarily mean one thing. And that's tricky too, when, you know, we have a new drug and we say, oh, this improves the FRS by 2 or 3 points. Well, what does that mean? Well, it kind of depends, right? Because a change from a 48 to a 45 might actually be different than a change from a 30 to a 27. So it makes it harder to interpret, you know, what these small point changes actually mean. And it can also make clinical trial interpretation a little tricky. So to kind of summarize that, what you really want in a scale is that like a 1 point measure is a consistent step measurement of function across the scale. But what we see the FRS does is a point could be like a big change, it could be a little change depending on the item or the question. So, it sounds like I know there's a lot of frustration with the FRS, but it hasn't been all bad. I mean, it has led to, like I said, it did increase efficiency compared to just using survival, and there have been some successes. So this is an example of the phase 3 study that led to the approval of IV edaravone. So they studied 137 people with ALS. They got 6 months of treatment, and they used the ALS-FRS, so this 48-point scale, as the primary outcome measure. And with 6 months of treatment, you could see that the patients on edaravone progressed a bit slower than the patients who got placebo. And this ended up being a 2.5-point change on the ALS-FRS. And when they looked at statistical significance, it was significant. So this led to our second approved drug for ALS. Likewise, the Amylyx trial, which is had some successes, also used ALS-FRS. So it has been helpful in some of our contemporary trials and allowed for smaller studies. But there's also been some studies where it's led to some confusion. So the Neurone or the Brainstorm study, I know there was a lot of excitement in the ALS patient community. And the kind of predefined endpoint for this study was going to be that patients who had a 1.25 point improvement in their ALS-FRS slope were going to be called a responder. So that would be considered a response to treatment. But the problem was that 28% of the placebo patients, so patients who got no treatment, actually met that responder criteria. So it ended up being a negative study. It didn't show a benefit. And in fact, this kind of responder definition wasn't a good one because many placebo patients met this responder criteria, which means that isn't actually a measure of treatment response, but just something that can be seen with this scale. They also had this endpoint looking at how many patients had a 100% improvement in their ALS-FRS-R slope. And again, this was intended to be another marker of improvement, but you see 13 patients with treatment and 13 patients on placebo both had that outcome. So this is a case where having the FRS as the primary outcome actually resulted in a lot of confusion and didn't really give a decisive answer. And that's kind of the worst outcome you can have, right? Like, we know that testing drugs, some are going to work and some are not. But if a drug doesn't work, the goal is to decisively prove it and move on. When you get these kind of nebulous results, that's sort of the worst possible outcome because the study doesn't answer the question and then you don't know where to go from there. So, showing that, some of these issues with the FRS are actually of practical importance, right? It's not just kind of this mathematical, theoretical problem. So this certainly wasn't a summary of all ALS outcome measures because there are lots of other things that have been tracked in trials, but I kind of wanted to hit the ones that are usually the primary outcome measure and what we use to judge success. So in traditional trials, so we talked about survival. So, I mean, it's still something that we do care about and track, but when it's the primary outcome measure, there's just an efficiency problem. The studies have to be very long, you require more participants. And the good news is that we have a lot more drugs on the pipeline that we want to test now than we did in the 1990s. So there's this need to do more efficient trials because we have many agents to test. And so that's a good problem to have. But that's why survival as an outcome measure is not necessarily our best choice. So again, I don't want to totally discount the ALS-FRS because for now it is the measure we have that has been used to improve trial efficiency, and it is very accessible. It's easy to administer. It's non-invasive, and there have been some recent successes with this measure. But, there are these limitations that we talked about. And so it just makes sense to look to moving forward, can we improve our outcome measures so that we can do more efficient trials and avoid some of the problems we've seen in the past? So there's a lot of new outcomes on the pipeline. And I know it's harder to get excited about outcomes than to get excited about, say, the new treatments. But like I said, I think we need better ways to measure change in trials so that we can get to these new treatments faster. So that's why this is important. And, drug development takes years and years and lots of money, but doing better outcome measures and smarter trials can be adapted, hopefully in a faster fashion. So I think that while talking about like math and outcomes is not everyone's favorite topic, it is very important because it's kind of low-hanging fruit for getting to faster therapeutic development in ALS. So there's many new outcomes on the pipeline. I'm going to talk about two that I'm working on. So one is the Rhodes, or the Rasch-Built Overall ALS Disability Scale, which is hard to say, so we'll call it the Rhodes. And then one that is kind of hot off the press and not published yet, but will be soon, is this telemedicine exam scale. So the Rhodes is a validated outcome. It's a pure patient-reported outcome. So unlike FRS, which is administered by someone else in a trial, this one is designed for people with ALS to just directly report their answers. And we were sure to design it with a lot of input from people with ALS to make sure that the questions had the input of patients who would be completing the scales and took into account things that we on the other side might not have considered. It's very reliable. And there's some key mathematical advantages over the ALS-FRS, which I'll try to not make too boring, but essentially there's ways to measure, when you do this Rausch analysis that we used in the Rhodes, to measure that all of the items on the scale are actually measuring disability and not something else. So when you add up all the items, you're adding up items that are capturing the same thing. And then there's this weighting of the scale that happens on the back end that makes sure that a 1-point change is like a measurable unit of disability across the scale. So like a 2-point change is twice the change as a 1-point change anywhere on the scale. And so that ends up being important when you're using the total score. And it targets kind of a broader range of ability levels. So it should be able to better detect change at kind of throughout the course of disease in ALS. So this is what the instructions look like. So each item is scored the same way using a 0 or a 1 or a 2. Essentially a 2 is if the task is normal and performed the same way as it was before someone had ALS. A 1 is kind of any abnormality, but so if it's slower, if it's less efficient, if it's more difficult, if you need some kind of assistive device or some kind of modification to do the task, then that would be a score to 1. And then a 0 is unable to do the task. And then these are the 28 items on the scale. They're in rank order from kind of the easiest to the most difficult. And it just involves tasks that are generally kind of day-to-day tasks that could be impaired due to ALS. And we've found it takes on average about 3 to 4 minutes to complete this. So it's usually pretty quick. And this is kind of a plot of the difficulty level of each question. So it's for kind of the overall score, the probability of answering a 0, the probability of answering 1, the probability of answering a 2. And this is what you kind of want to see for scales, that this is stepwise. Like if all your questions are the same difficulty level, you're not going to be able to capture different levels of change. But you see this nice kind of stair step of difficulty level where it's kind of showing you visually that it's capturing like a broader range of abilities. And then I know this is not an intuitive graph, but I'll try to walk you through it. So each person with ALS is a little 0 here, and where they're placed on kind of the vertical line here is based on their overall disability score on the Rhodes. So someone up here has very little disability and someone down here has a lot of disability, and you see there's kind of most of the patients are here in the middle. And then each question, so these are each of the Rhodes questions, and these are each of the FRS questions, and they're placed on their overall difficulty levels. So you can see that the Rhodes is capturing this broader range of ability that kind of mirrors the population versus the FRS, which is on this narrow range of ability levels. So we talked kind of about this responsiveness issue, that you want a scale that's actually going to change over time and hopefully change faster. And we think that Rhodes is more likely to do that based on this kind of broader targeting here. And then reliability of a scale is important, because anytime you have decreased reliability, it increases the kind of the noise of the measure, and you essentially need more patients to detect change when you have a less reliable measure. And the Rhodes ended up having very high reliability. That's about 97% reliable when you look at 2 tests within 7 days. The FRS reliability tends to range between 88 to 95%. Higher numbers when it's the same rater, and lower numbers when it's a different rater each time. So the reliability being higher should allow you to have less patients in a trial and still see an effect if it's there. So to kind of summarize the Rhodes, so it's a simple patient-reported outcome. It's got these mathematical advantages over the ALS-FRS. It's very reliable. But before people want to put a measure into their trial, they really want to see what it does in the long term, see these big data sets. And so, getting more long-term data on the Rhodes is going to be important before it's kind of the mainstay in ALS trials. And then I want to talk about this kind of new ALS telemedicine exam scale, which is something that hopefully will be published and validated soon. So this came to be because, we do in the clinic and in research studies, we routinely do neurologic exams. And for us as clinicians, it's useful. We can, we learn a lot from this exam data. It tells us how a patient is doing, but it's not captured either in the clinic or in research in a way that's actually used as an outcome, which is really a missed opportunity, because we're doing these exams and we know they're helpful, but we just don't capture it in a way that's used as a measure in trials, or used as kind of a numeric way to track progression. And then, especially with the pandemic, at most ALS clinics around the country, telemedicine has really become a mainstay of ALS care. And we've learned that we can track progression pretty well on telemedicine. But again, there's really no uniform way of doing these exams or capturing these exams and quantifying this in a way that could kind of objectively track progression. So this is kind of the background of why we thought doing this scale would be important. Like, why not use the data that we're already getting in a way that actually helps us track progression and can be used in trials? So that was that. We could spend the same time and effort and the same effort that patients are already putting in, but capture this neurologic exam in an objective and outcome measure for ALS progression. And then the same kind of math, this Rausch method that we use to make the Rhodes, we can use that when we do the scoring of the telemedicine exam scale to make sure that this final scale has like all those same characteristics that we want to see in a patient-reported outcome. We can do that same kind of math with an exam-based outcome. So this is the draft version. So once we do the Rausch analysis, the categories might end up getting changed, or some of these questions might get thrown out, but it's pretty simple. So we have the patient do things like touch their chin to their chest and lift the head back up, squeeze the eyes tight. We judge their speech, puff air into the cheeks, stick out the tongue, count as far as they can on one exhalation, elbows up and down, kind of a bicep curl, extend the fingers, squeeze the fingers, raise the arms up. If it's sitting up unassisted, standing up from a chair, walking, sniff, cough, and tapping the fingers. And then based on that, so far we have over 200 people with ALS that have done the scale for us, and we've done some retests to make sure that it's reliable with different raters, and we're hoping to finalize this soon. But we're encouraged by the data analysis we've done so far, and feel like this could be another really useful way to track progression. It's just a shame not to use this data when we're getting it anyway. And it'll be nice to have kind of an objective outcome that doesn't just rely on self-report. So we're excited to see this come to be, and it could be a useful thing. So I wanted to kind of end with how can people with ALS help us to accelerate therapeutic development, kind of based on what we've talked about. So I hope I've convinced you that kind of how we measure change in an ALS trial actually matters a lot. And while we have some outcomes in our toolbox now that are being used, we have room to improve the way that we track progression in ALS trials. But before a new outcome measure is going to make it into a trial, we really need observational studies to see how this outcome measure performs in kind of a broad group of people with ALS. And so, it's always a little harder to sell an observational study because there's no treatment for the people involved, but they really are important so that we can learn everything that there is to learn about how to track progression, and then do that in a very smart way when we do interventional trials. And the nice thing about most of these observational studies is typically they're open to all people with ALS, or most. And the study I'm going to talk about today that we're doing is pretty much open to all people with ALS, which is nice. I do want to mention that, we know what we know about ALS often based on who's doing these observational studies. And so we really want them to represent the actual ALS population. And one thing that it's not unique to ALS, but it is a problem in our ALS studies, is that Black patients and patients of color and patients in minority groups are underrepresented in our ALS research. So the CDC ALS registry, which tries to capture all ALS cases in the United States, says that about 80% of ALS patients are Caucasian, and that could be an undercount because it's possible they're missing cases. But in our clinical trial database, 95% of patients in clinical trials are Caucasian. So what this means is that a lot of our research on ALS is really reflecting kind of white people with ALS, and could maybe not be generalizable to the whole ALS population. So just kind of a pitch, and this is more for, I think, us as researchers and clinicians and scientists need to do better at making sure we're reaching out to kind of our whole patient population. But it is important that we do a better job of incorporating trials that are representative to the whole ALS population. And then one problem we see in observational studies is fast progressing patients tend to be underrepresented, and we tend to get a lot of very slowly progressing patients. And this is speculation, but I think that when patients are first diagnosed, they're kind of overwhelmed, and they're trying to A, get into an interventional trial, and then B, just trying to figure out how to manage ALS. And I think patients who've had ALS for longer and are slower progressing are probably more able to participate in some of these observational studies. And we love our slow progressors and certainly aren't discouraging anyone, but we as clinicians need to do a better job of reaching out to patients with fast progression to make sure that when we do these observational studies, it kind of captures the whole ALS cohort. And so we're doing currently at Emory this DoD, this is Department of Defense is funding the study. And the idea is to get some of these newer outcome measures ready for clinical trials so that we can get good longitudinal data in a representative cohort of people with ALS to know exactly what these outcomes do over time. And then these outcome measures will be ready to put into our clinical trials, and hopefully our future trials will be more decisive and more efficient and give us clear results in a faster way. So the study is going to look at the Rhodes, that the patient-reported outcome that we talked about with monthly collection, and this is going to be online. We're validating the telemedicine exam scale. And I probably don't have to tell this group that diagnostic delay is a big problem in all of ALS, but I don't know if you knew that it's even more of a problem in patients who are Black and people of color. We found in our population that Black patients actually had 8 months of a longer diagnostic delay compared to white patients. And so we're trying to kind of map out this diagnostic delay and try to understand where in the process is this diagnostic delay happening, and try to kind of better understand that problem and that discrepancy to see where we could target future efforts to do faster diagnosis. So these are kind of the three things we're looking at in this observational study that we're doing. It's very broad inclusion criteria. So it's open to any adults 18 or older, need a diagnosis of ALS or an ALS variant. So PLS or PMA or some of these kind of ALS subtypes are included in the study. And then the participants with ALS do need to be able to provide informed consent and provide answers to the questions, but they don't have to be the ones to write or click the answers as long as they can communicate it in some way. And a caregiver or a helper can be the one to actually enter the answers. And so for this study, the informed consent is all done online. We do have a research coordinator that can be reached for any questions or concerns or troubleshooting. So there is this baseline demographic information and some clinical information and kind of this information about the diagnostic process so we can kind of understand the diagnostic delays. And then the Rhodes and the ALS-FRS are completed monthly for 6 months, and that's done online. And there is the ability to stay on longer, but we're hoping to get 6 months of data from participants who can do it. And then there is one telephone visit within 7 days from an online one, just to compare the Rhodes and FRS from the web to the phone to kind of see how reliable that is. And then we're also looking at this telemedicine exam scale. So that'll be done twice within 7 days with 2 different examiners so that we're able to confirm the reliability of that scale. And automated reminders go out each month. So it's not something you have to remember to do. And, you know, because this is an observational study, it's not like if you miss one visit that you're kicked out or anything, you know, we'll take the data that we can get. I mean, we want people to do as much as they can with the protocol, but if it's not perfect, that's okay too. And I put in the link here and we can probably email it out or anything, but it's on the Emory website as well. For anyone who might want to participate in this study, you would just click on the link and you give your information and then you get kind of emails with all the details. There's also some YouTube videos that kind of go through it. If you like watching me talk, I explain it in a little more detail in there. So we would happily take any patients with ALS who might want to do our study. And that's all I have, because I know it was kind of a complex topic and I wanted to make sure I had plenty of time to answer any questions and kind of clarify anything that might, any lingering questions, but I appreciate your attention and I'm happy to answer what I can.
Well, thank you for that presentation. I think it hit a lot of chords, got a lot of questions, so I'm going to dive right into it along with Casey. We're going to go back and forth from the questions that we pulled from the chat. And
Okay.
If you still have any more, feel free to put them in. The first one is a little bit of a general question.
Okay.
Do you think the number of ALS cases are increasing? And if you do, why do you think so?
That's a good question. So we aren't necessarily seeing an increase in diagnosed cases, but people with ALS actually are living longer compared to decades ago. So we are seeing more patients with ALS when you look at kind of current people living with ALS, but it's not necessarily like an increase in new cases. But that is something that the CDC tracks pretty regularly, and they're looking for kind of geographic pockets and things like that. So it's something that is being monitored, but there's not a clear increase in kind of new diagnosis cases that we've been seeing recently.
Thank you, Dr. Fournier, for the presentation. So my first question is, do you think that the ALS-FRS scoring for trials is outdated? What would be a better method of measurement?
So yeah, I mean, I think both. So yes, I think we could do better than the FRS, but no, I don't think we're ready to throw it out today, because again, going back to, we have to have something that's kind of ready for prime time. to just get rid of it. And so I think that there's this willingness among kind of drug companies to start including new outcomes as kind of secondary outcome measures to see how they perform. And eventually the FRS might not be used at all, but right now it's still, I think we still need it, but we need to see if we could do better. And that's kind of what I'm working on is kind of trying to come up with some of these adjunct measures and things that could end up being primary outcome measures in the future. Another thing I didn't touch on, but that's I think super important is biomarkers. So we're more and more trying to get, things you can measure in the blood or in the spinal fluid that show that the drug hit the target that you wanted it to hit. And if we get good biomarkers, then those could really be a more precise measurement than some of these kind of broad clinical outcomes. So that's something that's super important and a big area of interest as well. But I'd say it's still kind of early. Like we're not at the point where we can use a biomarker as something that's better than a clinical outcome. But I think everyone's realizing how important biomarker development is. And there's a lot of observational studies to try to come up with better biomarkers too.
There was a question that played right into that, and I want to see if I can get it real quick because you perfectly segue right into it. Let me just see if I can find it real quick. It's right here. Because the ALS-FRS scores are the total measured after taking in different factors into account, are the trials using the ALS-FRS scores, particularly looking at specific improvements, for example, speech and balance, or is it just overall score improvements?
So in general, it's overall score, but there are certain studies that have looked at specific domains, and some of that depends on the mechanism. So for example, there was a study of Nuedexta, which is used for kind of the laughing and crying in ALS, but there was a question of whether that helped specifically with speech. So in that one, they looked more specifically at like some of those speech questions on the FRS. And then there were some trials of like tirasemtiv and some of these drugs that are skeletal muscle activators. They thought specifically to increase muscle strength. And so they looked at some of the motor domains more specifically because it kind of related to the mechanism. But in general, they're looking at the whole total score. But there are, yes, you can analyze like domains or just sub-specific questions, especially if you have a drug that might target like a specific region.
How do you deal with statistical outliers that has such a slow decline over 2 or 3 years?
It's a good question. So there's a few different ways to do it. So some of the recent studies, like the Amylyx and the edaravone studies, essentially excluded slow progressors. So they only enrolled in their trial patients that were progressing very quickly, which is more of a statistical strategy than like a biologic one. So essentially, if everyone that you enroll is progressing really quick, you can just measure that treatment effect faster. But like I said, it is a balance, because if you pick such a small subset of your patients in the trial, then you're left wondering like how generalizable is that treatment effect that you see. And it also ended up being kind of a practical problem where like for edaravone, for example, some of the insurance companies are being very literal with it. Like we will only pay for this drug if you like exactly match the criteria of the trial. So I think in an ideal world, we would be able to just measure change faster so more people could be included, but we're just not there yet. But the strategy currently seems to be to kind of exclude slow progressors from the trial so that you can measure effects faster.
Switching gears here with the scoring, is the Rhodes scoring method currently recognized or used in any neurology circles with ALS?
So yeah, the Rhodes right now is being included as an outcome in multiple trials. It's just not the primary outcome. So the primary outcome is kind of what you say it works or doesn't based on and how you design like the size of your study and how long it is. And it's right now not being used as the primary, but it is being included in trials so we can get kind of that real world trial data and then get that head-to-head comparison of the FRS and the Rhodes and in real studies. And then it's being used in some clinics. I mean, I made the Rhodes, so it's a little biased, but like we get it on every patient at every visit at our center. And I found it to be easy, but I made it, so it's probably not the standard across the country. But no, it is being used more, but it's relatively new, so it's not as mainstream as something like the FRS.
Our next question is, in your opinion, what do you think is the best way to get underrepresented PALS into trials and studies?
That's a really important question, and one that we're thinking a lot about at our center to try to do better of this. I think we're trying to recognize if there's any biases in the way that we do things and address those. We understand that there might be more distrust among certain communities, which is based in historical fact, right? There are groups of people that have been kind of discriminated against by the healthcare system, or people who've been experimented on historically and, don't trust kind of being a guinea pig. And so a lot of that can be broached with just building relationships with our patients and addressing concerns. And also we're, mindful of, does our team match the population of the patients that we're serving and things like that. So I think it's not like a one size fits all or an easy solution, but I think kind of acknowledging that this is a problem and coming up with kind of active strategies to deal with this is really important, and something that we're working on, constantly to try to do better with this. But it's not a simple solution, I don't think. And I think from the patient community, if we always are happy to hear feedback, if there's something that we could do better, that you guys can see from your side, we always want to hear that.
I'm glad to hear that, because I know it's staggering the lack of data there is with, certain communities that are actually quite large. So I'm glad to see that that's being addressed. This one pertains to a specific study, so forgive me if I'm not completely familiar with it. Have you looked at the digital biomarker study published this year using objective measures? And if so, what were your thoughts on it?
Yeah, so the digital biomarkers it's a really exciting and could have been its own talk, and maybe it will be for you guys. But there's all kinds of things that, whether it's measuring breathing using a home device, or kind of motion sensor things, or capturing speech on your phone, there's this whole new world of kind of at-home capture, because the technology has just blown up in the past few years, right? So there's a lot of things that can be captured at home. I don't think the challenge is kind of figuring out what to do with all this data and making it clinically meaningful, like all these different motion sensors, and you get this velocity and this acceleration and this many movements per hour. And we're just not at the point where we know exactly what to do with that data. So it's coming in really quick. And I think that the studies like the ones you mentioned that are kind of tracking these things have shown that it's feasible, that it can give us some useful data that correlates with kind of other known outcome measures. But I think we still need to figure out kind of what to capture, how to capture it, and kind of what is the most clinically meaningful. So yes, I think it's really exciting, but I think it's kind of like with this Rhodes and the Telemedicine exam scale that I talked about, where we still really need more long-term data from kind of a broader cohort to really know how to use it in a trial. And there's multiple studies that are looking at digital kind of markers. And so I think we're going to learn a lot more about the best way to do this in the upcoming years.
Going back to Rhodes, someone asked, would Rhodes even be applicable for an individual with long-time ALS, for example, 26 years since diagnosis?
So it is true. I mean, we don't have a lot of patients with 26 years of ALS. So most of our outcomes are that patient, it would probably be an outlier for many of our scales, right? When we did the Rhodes, we're thoughtful it was validated in our entire clinic. So it was kind of capturing the full gamut of patients that come into an ALS clinic, which is a much broader population than what goes into a trial. But yes, I think any of these scales might struggle a little bit with patients that are kind of very different from a typical ALS patient. So, and I think it would depend on kind of how that patient's doing after 26 years, which would be variable too. So I wouldn't say that it's not applicable, but that it's just, there weren't many patients that fit that description that we were able to test with the scale. So it isn't tailored to these very long standing patients.
I believe you touched about this a little bit, but perhaps you can go into maybe a little bit of clarification. Would caregivers be able to score the telemedicine scoring you spoke about, or would it need to be done with a trained professional?
So the way we're doing it now is that we're on a video conference like this with someone like me as the examiner, and then the patient and potentially their caregiver on the other side. So we would need to actually see the patient, and we are the ones as the examiner scoring it. But as kind of a next gen thing, we are looking into like, can this all be done, say, on an app and a phone, not involving me? And that is something that we want to do eventually, but we haven't validated that yet. But I like where you're thinking, because that certainly would be easier, right? To just pop out your phone, do your kind of exam assessment for the day in 2 minutes and go about with your business, rather than having to connect on a Zoom and all of that. So yes, we think that is a great idea and hope to do it, but it's not quite prime time ready.
Our next question is there anything from a behavioral health aspect that you'd like to see or that can help in assisting this area of research?
I have to think about that. So I wonder if the person, I don't know if I know what is being asked. I want to make sure I answer the question. What? And I'm lost in the chat, so I don't know who to ask. Let's see.
I believe it came from an individual who worked in behavioral health.
Oh, I see. Okay.
Yeah.
Should I just speak?
Yeah, that'd be great.
Hi, we kind of do a lot of like pain, fatigue, stress management for patients with chronic disease and illness. And so there's not really a whole lot of that in terms of the ALS focus. And so just kind of wondering, with the Rhodes, that's definitely something we do, where we do questionnaires with patients, and just kind of generally speaking, how can behavioral health be integrated into all of the various ALS research?
Yeah, that's a really great question. So we know that the things you're talking about, like pain and fatigue and caregiver burden and just kind of, depression, anxiety, stress, like these are all important issues that need to be addressed in ALS. And there are some scales for some of those things. Like there's a specific caregiver burden scale. There's like a fatigue severity scale. So we do have tools to capture those things. I know on the clinical side, it's something that we address a lot in kind of our overall care, but I don't know that there's a lot of kind of formal interventional studies to make these things better, but I think it's important and there should be. So I think we do have some tools to measure that, but it's certainly an area that could use more research focus to kind of work on quality of life and that kind of thing in our ALS patients. So I hope to see more of that.
Next question is it possible that fast progressing PALS progress at such a rate that by the time they get educated, it's too late to become involved in studies like these? And if so, how do we fix that?
Yeah, that's a really tough question. I do think that if we got better at diagnostic delay, that would help a lot. So if someone is getting diagnosed and they're already battling kind of some of these, later complications of ALS, then the last thing on their mind is going to be, oh, how can I help by doing this observational study, right? When you're already kind of in crisis mode when you first get your diagnosis. So I think from our end, like earlier diagnosis would really help with this, so that there is more time to kind of process the diagnosis, make a plan, deal with, symptoms as they come. And then I think just from the clinic standpoint, recognizing patients with fast progression earlier, so we know to offer more support early on to these patients would certainly help. So it's tough. I mean, I don't know that there's an easy solution because it's just really, really horrible to have fast progressing ALS. But maybe one day when we have such awesome treatments and we can turn fast progressing ALS into maybe slower progressing ALS, that would fix the problem, right?
Following the previous question with underrepresentation, what analysis has been done to evaluate exclusionary criteria being biased against fast progressors, thus causing underrepresentation?
So it's a tough question because the goal is to get drugs that work approved as quickly as possible, right? So you have to balance, like if you don't exclude the slowest progressors, then it's going to take longer to do your trials, and no one wants that either. So I guess there isn't a single solution, and there's not a universally accepted approach is the short and honest answer. And every trial is a little different. But I think if we had better ways to measure change faster, then there wouldn't be as much of a statistical need to kind of select this really specific population. And if we had biomarkers that could measure change in a quick way, then that would also be another way around this issue, that maybe the patient clinically looks slow, but if you can measure in their blood that they're responding, then that would be a way around it. So hopefully that'll be something that we can do in the future.
This is a perfect question for you since you helped create the Rhodes scoring. Acknowledging that the limb onset and bulbar onset are different in their respective progressions, do you think we should have separate scales for each progression?
So it's a loaded question. It's not. So our goal was kind of with the strategy of regulators in mind, with that the FDA and kind of approvers do like to see these overall scales that do correlate with survival and kind of reflect the overall status. So it's not to say that a bulbar scale and a limb scale don't have a use for tracking progression or for looking at different subtypes differently. But if you're trying to get a drug approved for this whole population, then you need a scale that kind of tracks everything from a strategic standpoint. But yes, if you had like a drug that was specific for bulbar onset ALS, then you would want a scale of things that focus on that group of patients. So, but since most of our current trials are focusing on bulbar and limb onset patients in the same trial, because we think that they have some of these same kind of molecular pathways at play, we need a scale that can kind of capture everyone together.
And our last question is, from a real world perspective, do you believe that treatment for ALS will be polytherapy or monotherapy?
Yeah, I do think that if like one drug was the answer here, we'd probably be there already. I think a lot of it is that I think it's probably many things, and I think it could be different things for different people with ALS. So the one thing that some of us think that might be why we haven't been more successful is that maybe, say, looking at all of you, we call all of you ALS, but maybe, you would respond to drug A and you would respond to drug B and you would respond to drug C because there's something kind of biologically that's different about each of your diseases, and different treatments would be the answer. So I do think that, and we've learned a lot about that with like the genetic forms of ALS, and so, but I think there's probably more to that in sporadic ALS also. So I don't think it's going to be one treatment fixes all of it. I think once we kind of understand the biology better and the genetics better, then it might be that we, need biologically different patients, not just patients that look different, based on how your arms and legs move and how your speech is, but things that are kind of happening that we can't see that would lead to different treatments.
Well, thank you again, Dr. Fournier. This was an absolutely incredible presentation. I think it yielded a lot of information for us. We want to be respectful of your time. This is usually the portion that we no longer record. It's an open forum for everyone. You're welcome to stick around, but we also understand you're very busy. So it's no offense if you have to bounce off.
Yeah, it's 8 Eastern time and I hear my kids in the background kind of getting unruly. So I think I will leave you, but I'm happy to like field questions by email if they come up afterwards. So feel free to shoot me any
Dr.
unresolved
Christine?
questions after. Do you want me to pop that in the
Doc-
chat?
Yes, please.
Okay. All right. That is my email address. So if I left something out, feel free to reach out. And then if there is a way to distribute like the flyer for the study I talked about, I'm happy to get that out to you guys as well.
Yeah. Thank you so much, Christina.
All right. Really nice to talk to all of you today. Thank you.
Thank
Thank
you.
you.
Have a great evening.
Thank you, Dr.
Thank you.
Christina.
Yeah.